I want to welcome you to the last ASAN summer webinar of the American Society of Addiction Nursing. We've been holding these webinars every Tuesday from July 6th, and today's the last one. Share my screen will go. Okay, I also want to thank our sponsors, who happens to be FS Solutions, Recovery Management Solutions, which happens to be my company. So we're a proud sponsor of the webinar platform here today. I want to remind people to keep their cameras on and also to mute your mics. We've had some situations in the past where mics were not muted and it was disrupting the presenter. Anybody who has any questions, please post them in the chat box. You can find them at the bottom of your screen, probably in the center. There's a little chat box there. Just post your questions there. Dr. Ferguson and I will be reviewing them during the presentation. You must complete the daily session surveys. A link is found on the schedule on our website. Actually, when you complete the survey, you'll get your CE certificate probably within a minute. It's immediate. You really see it's instant gratification. This conference has been approved for 8.0 nursing CEUs to the California Board of Nursing. That's for the entire session. This session itself will be 1 CE. Just complete the surveys and you'll receive the completion. I want to thank E.M. Garcia from California for getting this approved, along with Al Rundio and Connie Neely for coordinating these webinars this entire summer series. If anybody had missed the session and you're interested in seeing any of them, all of our sessions are recorded. This is being recorded now. And you can go back into the archive and fill out the survey and you'll receive a CE for the session. This is our board of directors. Bill Carrick is our board of director. I am Susanna Looney. I am president-elect. Bill Lorman is our treasurer. Ginny Coletti is our recording secretary. And Carolyn Baird, who is on this call, wave, she's here. She's a board of director, along with Fran Campbell. She's here too, I believe. And Mary Fouget, she is also here. Give a little wave so we can see you. Again, this is our last one for the summer series. I have to get up my, I have to get my welcome for Dr. Ferguson. So today's session is Dr. James Ferguson. He is Medical Director of Recovery Management Solutions of FS Solutions, located in Chalfont, Pennsylvania. Dr. Ferguson, I do have the pleasure of working with him. He is our Medical Director and MRO at FS Solutions. He serves as Chairman of the Medical Review Officer Certification Council and is a former member of the SAMHSA Drug Testing Advisory Board. Dr. Ferguson was also course director of the ASAM MRO training course until 2013. He is author of the MRO Team Manual, as well as co-author of the MRO chapters in the Principles of Addiction Medicine and the Handbook of Workplace Drug Testing. He is a diplomat of the American Board of Addiction Medicine, ABAM, and he's also a distinguished fellow of the Medical Society of Addiction Medicine, ASAM. And I want to thank you, Dr. Ferguson, for presenting tonight. And I will stop sharing my screen so you can bring your screen up.
All right, we will see if I know what to do now. Just because one has credentials does not mean one can figure out how to do this. Okay, can everybody see that intro slide? Nod your head, Suzanne. Yes. Okay, I got a thumbs up from Mary. Thank you, Mary. Appreciate it. Okay. I am glad I'm not doing 8 hours tonight. I've actually put, I think there are 60 some slides out there, and don't worry, ladies and gentlemen, we're not going to get all the way through them. But I wanted, you know, some of them can be available as references down the road. And that's my main point in putting some of the charts and everything out there, not to give you a quiz to get your educational units afterwards, just so you'll have them available down the road. When we teach the MROs, we tell them the same thing. But MROs, though, unfortunately, have to memorize this for the certification exam. They can forget them the day after, just so they know where to find the there we go. Okay. So we are going to hopefully do a introduction to these 5 things. I really would like you to leave here maybe with some good ideas about the first 3. And we're going to show some interesting cases, maybe addressing unexpected metabolites and what you do when the laboratory tells you something you're just not expecting to see. The main thing I want you to understand is different specimens, how they relate to each other, how they are different from each other, how they can be used together, what they mean, and sometimes most importantly, what they don't mean. To do that, we have to address validity testing. And at the very end, we're going to touch on alcohol biomarkers. That really is an entire lecture in itself. Maybe if Suzanne invites me back, we can do one just on alcohol biomarkers. I'd rather not spend a whole lot of time today on them because in the age of COVID, with all the attention being focused on alcohol as a cleansing agent and alcohol's different uses other than as a beverage, we're getting a lot of very pertinent research being done to find out how those significantly increased uses actually affect the laboratory results. All that info is not in yet. Hopefully by the time you resume these talks, some of that will be in and we can address them. So we're going to touch on them, but not spend a lot of time on them. We're going to spend most of the night talking about specimen and how they relate to each other. We're going to have 8 cases. We're not going to go over them all, but we're going to talk about unusual results. Most importantly, I think, validity testing. It's really, I think, very important. Maybe the most important thing is to know your specimen and know how much you can trust the result that you're seeing from the laboratory. I think that's the big take-home thing. We, in this kind of monitoring world, rather than a clinical world, in a monitoring forensic world, we do 2 different types of drug testing on every single specimen. I'm starting with this because I don't think this is completely understood across the board. If you do understand it already, and I'm telling you something you already know, forgive me, it'll be fast. Every specimen goes through multiple tests, every single one of them. The first step is a very, very sensitive step called screening. Most of the specimens that we see, even with the populations that we're testing now, the vast majority of the specimens that we see are going to be negative. There's nothing unusual or inappropriate going to be in those specimens. The idea of screening is to be very, very sensitive, to go through the entire batch as quickly as you can and rule out the specimens we don't have to pay any attention to. Those are the ones we like. But we're going to spend all the time on the non-negative screening specimens. Now, we don't call them positive. Screening tests are not that specific, so you can't call them positive. You can, if you want to, maybe call them presumptively positive, but they are not positive. All we know for sure is that they're not negative because they didn't get through screening clearly. When that happens, they go to the second step. Second step is confirmation. This is a laboratory step. If you all are doing quick tests, point of collection testing in your treatment centers or in your clinics, those tests are screening only tests. They are sensitive, they will pop for a whole lot of things, but you just can't really hang your hat on what it's telling you because it's not specific. Technology is getting better. The point of collection screenings are getting better, but they're still not specific enough to really take any kind, certainly of a forensic action, certainly of a disciplinary action. They're good for clinical interpretation because you can sit your patient down, your client down, your participant down and say, okay, this is being triggered here. What can you tell me about it? And you can then have a clinical discussion about it, but you really can't have a forensic discussion based only on a screening result. So in the laboratory then, those specimens go to very, very specific confirmation. That's where the instrumentation costs $500,000 a pop, and the technologists have to have years of experience because the instrumentation has to be calibrated and the reagents have to be refreshed and all the tubes have to be flushed and all that yada, yada, yada stuff has to happen. It's very complicated, very human intensive and expensive. So the screening is getting better, like I said, so the vast majority of those presumptive positives that we just talked about that wind up going to confirmation are going to confirm positive. And the results then are going to be called confirmed positives or invalid or some of the other things that we're going to talk about in a few slides. And keep in mind, while screening is sensitive but not specific, confirmation, depending on how you set the machines up, can be sensitive, but the most importantly, confirmation is very specific. Confirmations usually look for a molecule, one molecule, THC acid, as opposed to parent marijuana or one of the multiple metabolites of cocaine, benzoyl-ecgonine or norcocaine, but they look for specific molecules and they identify them. So I touched a little bit on the difference between forensic testing and clinical testing. When we get a forensic result, bottom line is I have to be able to testify in court about it if I have to. So that's why we go through all of these multiple testing steps, the validity testing steps we're going to talk about in a few slides. But because of the need to have that level of specificity and that level of confidence in the result, we use what we call cutoffs. We're going to talk specifically about cutoffs in a few slides. But because of those, I want you to understand the most important thing about a forensic test. The forensic test is negative. That doesn't guarantee that there's no drug or alcohol present. That just means it's a negative result. There are false negatives. There are false positives. A negative result doesn't guarantee the absence of anything. It just guarantees that there's no analyte, no drug, no alcohol, or whatever you're looking for. No analyte there at or above whatever cutoff we set. So there's different arguments about how to set cutoffs, which we can address. But the bottom line here is that all a negative result says that there isn't any analyte at or above the cutoff. So if we do get something at or above the cutoff, that level cannot tell you if that positive represents acceptable use of a drug or prescription or inappropriate use of that drug or prescription. It cannot tell you whether the person who submitted that specimen was impaired. There's only one drug alcohol / result that tells you about impairment. And you all know what that is. It's called a blood alcohol level or a breath alcohol level. And the only reason that tells you about impairment is because it's a legislated level. It's not a clinical level. A 0.08 or lower blood alcohol level is a legislated impairment level. There's no other level that we get out of all this testing that we do that tells you that that donor was impaired. None. There's also no dose-result relationship. If somebody's taking Adderall and you get a whole lot of nanograms of amphetamine in the confirmed lab result, we cannot relate that level to whether that person is taking the Adderall dose as prescribed. If you have enough of a testing history on the person so that you can see level after level after level after level over time, you can make a guess if all of a sudden the quant level shoots up and you can't explain it. Then you certainly maybe want to confront that participant. We still have to go with the bottom line truism. There's no dose-result relationship in urine testing, and certainly not in hair or any of the longer detection period specimens. I mentioned cutoffs earlier. The cutoff is just a number that you work, you compromise with the laboratory that you're using. The main reason that cutoffs are set, as I said, is a compromise. It's a cost-benefit ratio because the lower the cutoff you set, the costlier the test is. The lower the detection limit, the more work goes into it, so the costlier the test. You want to pick the level with the laboratory that is easy for the laboratory to get to and that most other clients of that laboratory use. That's called an administrative cutoff. That is the least expensive cutoff. You want to compromise and get that as low as you possibly can so it tells you what you want to know, but everything we do is a compromise. And this is a very expensive business we're in. I don't have to tell any of you that. So we want people to continue in the programs. We want people to do well in the programs. They want to be able to show the world when people are in recovery that they are in fact in recovery. And to do that, we have to make compromises, cost-benefit ratio. Other than the administrative cutoffs, we have as low as the lab can go. Those are two things, limit of detection and limit of quantitation. Those are very, very low, and that kind of testing is very expensive. There is arguments both for and against using LOD and LOQ testing. You may have been following the Olympics recently and reading about some of the sports testing that's being done and arguments from people testing positive in some of the sports arenas about how they might have tested positive for some anabolic steroids. When you get very, very low cutoffs, you know, the science kind of stops. And we really don't know how little it takes to actually cause a positive. When the other benefit that I didn't mention about administrative cutoffs is that there is a lot of science around them. The administrative cutoffs, one of the reasons that they're chosen is because of the science that says that, yeah, if you test positive at or above this level, pretty good odds that you ingested that specimen. It's very hard to get a positive at most common administrative cutoffs without ingestion. And that's been studied. There's a lot of research to back that up. When you start going down to limits of detection and limits of quantitation, sometimes all the bets are off about how those substances actually got there. And that doesn't do us any good in this kind of program. I don't have to tell you this. The main point of this slide is to show you the difference between the effects of the drug and when we can see them in the testing that we do. Notice, blood testing and breath testing is the only thing where we can get an immediate result. Blood alcohol is immediate. Blood phosphatidylethanol is not immediate. Blood PEth is a long detection period test we'll talk about later. There is no relationship between urine and hair results and impairment. Oral fluid, you can see on here, has a very short detection period. So there's hope. The science isn't in yet, but there's hope that at some point you can relate some oral fluid levels to impairment, but we're not there yet. This is just a nice looking slide I put on here to show you the difference in detection periods between the different specimens. Okay, for our purposes tonight, the longer the detection period of a specimen, the greater amount of drug usage required to produce a positive result. Hair, nails, blood phosphatidylethanol. They don't become positive easily. It takes a lot of use, with the possible exception of cocaine in hair, takes a lot of use for drug to actually get into the hair and stay there. All the drug results that we look at are two-dimensional. We can't tell you, without sequential testing specimens, we can't tell you if the analyte concentration is going up or down. That's why we can't tell you when the usage occurred. We don't know which way the analyte, the concentration is going. Given that, then results from different collection using the same specimens within detection window can help. You get sequential results that can obviously help. But because of the time period involved, it's still not exactly accurate. When you start using alternative specimens, you get perspective. You may also get some hints about total amount of usage, but they don't really tell you for sure how to interpret the original urine results in terms of the specimens going up and down. And that's because the detection period of those things are so long, it's really hard to pinpoint in that detection period where ingestion exposure, whatever, where exactly that happened, or if it happened once, or if it happened multiple times. And this slide kind of just shows you why, because the specimens that we're testing are different things. They're different body tissues. They have different uptakes. They have different retentions. They have different binding properties. They're all different. So we have a very hard time relating them. Important bottom line is a positive in one matrix does not invalidate or is not invalidated by a negative in a different matrix. Each result stands on its own. Perspective, yes. Invalidation, no. Okay. Advantages and disadvantages should be obvious for hair testing. Okay. Again, long window. We talked about that. Easy to collect. Yeah, well, we've seen some examples of some rather botched hair collections. You know, I actually had I had a very big head of hair before I had a test the other day. But anyway, generally easy to collect, handle, and store. They're not looked at as infectious specimens. So a lot of the shipping issues with urine are not present with hair. Theoretically non-invasive. I guess that depends on where you collect it. Generally, there are places of your body we do not want collectors to go. Beating a hair test may be more difficult than in urine, but if you're ever really curious sometime, go onto Google and Google, just in the search box, type in beating a hair test. Then when you're done with that, type in beat an oral fluid test, then type in beat a urine test and see how many hits you get. Understand that there's an entire cottage industry making a pretty good living developing products designed to beat any kind of testing that we can figure out. Okay. Disadvantages with hair testing, we talked about. You can't tell when the use happened, and it's not going to be recent. It's going to take sometimes 10 days after usage for that drug to show up in hair, if in fact there was enough usage for it to register in the hair in the first place. Cocaine and methamphetamine, especially basic drugs, cocaine and methamphetamine have very serious concerns for positives from environmental contamination. If you ever look at a hair positive that's positive for cocaine, especially cocaine, you have to look at the metabolites. You have to try to put those together and figure out if the ratios are there that can differentiate that cocaine positive from an environmental contamination and actual ingestion. I'm sorry, guys, it's just not easy sometimes. Hair color has an effect on drug uptake in hair. That is much more of an issue in workplace testing than in our testing. But people with hair with a high melanin content, notice I am not saying racial or ethnic differences. I'm saying a high melanin content in the hair, regardless of your race or ethnicity. Melanin in hair binds drugs more easily than hair that is low in melanin content. We don't completely understand, in spite of how knowledgeable I may or may not seem about this whole issue. We really don't understand a whole lot about drug uptake and retention in hair. Those time relationships are just not going to happen in hair. The other thing about hair testing is that if you're going to try to test really large panels of drugs, it takes a lot of hair. You can't just do a little simple workplace kind of drug panel for 15 or 20 drugs that we're trying to test for. It takes a chunk of that person's hair to really have enough hair to test all those analytes. There's different stages of hair growth. There's 3 stages: growing, transitional phase, and resting phase. Again, there's not going to be a quiz after this, but this will give you an idea about the different rates of growth on a person's body. And here's a really hard to read slide that puts it in a graphic form. If you see on the top line going across the scalp, has only 13% of its hair in the resting phase and 85% is growing. Not on my head, true, but many normal heads, 85% of the hair is growing at any one time. But if you go down to, say, legs and thighs, kind of turns around, doesn't it? 80% of the hair on legs and thighs is in a resting phase, and only 20% is growing. But while I say that a significant percent is in the resting phase varies from 3 to 4 months on the scalp to much less than that for some other parts of your body. So you're getting a mix of hair anytime you test. We only say that hair testing from the scalp looks back, if the specimen's of the proper length, looks back about 90 days. But there are different parts of the scalp that are resting and different parts of the scalp that are growing. We want hair collected one time from different parts of the scalp. That's fine. If the hair has to be recut 2 to 3 weeks later and it's taken from a different part of the scalp, you may get more resting hair, you may get more growing hair. You may have an entirely different drug test result 2 weeks later than you did from the original result. So just keep in mind that there's a tremendous variability when you're testing hair. All right, given that, this is going to be a quick case. 24-year-old male medical student with a history of alcohol and experimentation, referred by medical school after 2 alcohol-related incidents. UDS, phosphatidylethanol tests are negative. A random hair test was positive for amphetamine, but he claimed his last use of Adderall was long before the test. The hair specimen was taken from the pubic area because he had a head like mine. Couldn't get it from up there. So what does that tell you about his history before we even go to the next slide? If you're going to collect hair from a different part of your body that has a different detection period, what does that tell you about what his argument is? Are we going to listen to his argument or not? I wish we had, like hands or something we could go up, or I don't know if you're seeing anything in the chat, Suzanne, or something, but anyway. Pubic hair grows more quickly, but has a longer resting phase. So you know what? When you start pulling hair from below the waist, whether it be legs, hair, pubic, you can be looking at a year to a year and a half detection period. So that's one of the reasons we don't like to do it. Another sample, like I said earlier, you get a second sample, even from a relatively close area, it may be completely different. So we're going to accept that his history of amphetamine use was kind of supported by this series of hair tests. And he's doing fine. He's being monitored closely. Female physician with a history of prescription opioid dependence, depressive disorder and anxiety disorder, 3-month residential treatment, and signed a 5-year monitoring agreement. Several abnormal urine specimens were in monitoring. One was dilute, 2 were dilute, and 1 was overly concentrated. So when you see abnormal specimens, we're going to get to the point in this lecture where we talk about what to do with those kind of weird abnormalities. One thing you do is collect a different matrix. So she had a hair test. The hair test was positive for oxycodone, hydrocodone, and hydromorphone. But, always a but on these kind of cases, right? The participant claimed the hair was taken in the wrong place. Instead of cutting it close to the scalp, it was taken from the ends of her long, untreated but plaited hair, far out from the scalp. So the first thing that you want to do when that happens is talk to the collector. Now, this participant was referred for a recovery status evaluation that didn't understand, that didn't find anything else. And a repeat hair down the road was negative. So what happened? Like I say, we may never know for sure, but you want to talk to the collector and get the collector's history of what happened. I know we are in a profession where we are lied to an awful lot. That does not mean we don't have to look closely every time we hear a story. One of the things that we do regularly is talk to collectors. My staff is trained to do that, and I do that because we want to hear all the different versions of what happened. If somebody is saying that the hair specimen was incorrectly collected, we want to know from the collector whether that was true. What's the collector's side of the story? If she told the truth about the collection issue, then it becomes donor's word versus collector's word. And it becomes a judgment call on our part about who we take. The laboratory can attempt to identify hair orientation and length, but there are no guarantees. A lot depends on the collector with any hair test, and indeed with any oral fluid specimen, because those are directly observed collections, much more so than urine is. And the collector does it wrong, or sometimes there's just no way to prove it. So we have to take all that into consideration. But if it was done properly, we might still do a second collection, even though, as we said before, that's a brand new drug test. It will still give us information that we might be able to use. So we might be able to use the information, but that doesn't mean that the second test invalidates the first. It just doesn't. It may come from a different part of the body, or even if it comes from a different part of the scalp, it is still a different test. So it can add perspective. We have to get away from the idea that it invalidates the result of the previous test. In this particular case, because of what we discovered here, the participant was found safe to practice and is still in monitoring. So I hope an undercurrent of the discussion we just had has come through, that my opinion, and I hope yours too, is that urine testing is the forensic backbone. There's a lot more science behind it. There's a lot more case law behind it. There's a lot more experience behind it. So urine is the forensic backbone. Follow-up from other alternative specimens will help adding perspective, but will not invalidate urine results. In all drug testing, we like a mix of specimens. We like an unpredictable mix of specimens. Random testing is the key. Random frequency, random choice of specimen, and follow up. Most importantly, follow up unexpected results. Pick a follow-up specimen that will cover the period of time in question, and that will cover the drugs of concern for that particular participant. Do not expect that follow-up specimen to invalidate a previous result. Expect a follow-up specimen to put a previous result in perspective. I would discourage anybody to take a very significant action only on one hair or nail test result. Given the science now, I would not take an action based only on one test result. Even back in medical school, one lab result does not make a diagnosis. We're not doing clinical medicine here. We're not making diagnoses. But one lab result is a hard action to be taken just based only on one result. You want a history, you want a series of results, you want a series of behaviors. We bother with alternative specimens to provide a backup approach to a strong forensic urine testing program. Again, one drug test doesn't make a diagnosis, but it can add perspective to the total picture. And alternative specimen testing does the same thing for urine results. It doesn't invalidate them, as perspective. Okay, does anybody have any questions based on that before we kind of change topics here? Suzanne, anything in the chat? Suzanne, you're muted.
Surprise, surprise. We did have a question earlier about to address testing, in DUI. What's your opinion about levels combined with alcohol as more states move to legalize marijuana?
Yeah, that's another whole hour of discussion right there. There should be, like I said, the only impairment level we have from any of the drug testing we do is a blood alcohol or a breath alcohol level. And the only reason that we have that as an impaired level is legislation, not clinical. Sooner or later, if there's going to be any teeth involved in the driving under the influence of drugs, is going to have to be a legislated level. I will tell you from the Drug Testing Advisory Board research that was done before my term expired on that about year and a half ago. The states are looking at 5 nanograms per mil blood level of THC, parent THC, as the level for marijuana, as the impairment level. There's a lot of research out there from some of the SAMHSA funded things that are going on that's too high a level, that 2 nanograms is more of an appropriate level. But until that's decided upon and set, we really just don't know. And there is no good basis to have any kind of forensic approach to a driving under the influence of drugs program at this point. It's going to be a tough call. It's going to be a tough call when that comes. I hope that's kind of a non-answer, but that's really the best we have under the circumstances right now. So any other questions, Suzanne, before we flip to validity testing?
No, there is none.
Okay. It's always nice to know what you're testing. It's always nice to have a sense that you're actually testing human urine. So to do that, we have what we call validity testing. One of the reasons that I said earlier that urine testing is a forensic backbone of a program is because we have validity testing. You don't have any validity testing for hair, nails, or oral fluid. Now, there are some labs that are pushing certain things. There is just not good science behind it yet. Bottom line is, when I said the collectors are really important for hair collection and oral fluid collection and nail collection, it's because, you know what? There's not much the lab can do when they get the specimen. In theory, labs can tell when it's not human hair, but I can also show you some SAMHSA studies where the labs got fooled. How do they know, for example, from hair that it's from the same hair that the donor actually grew instead of just tied on? The collector's supposed to figure that out. Well, what happens if they don't? You can't expect the lab to figure it out. For urine, at least the lab has a chance to figure out whether it's human urine or not. Okay, we have validity testing. Validity testing's been in place for over 20 years. It's mandated, and frankly, if you all are in testing programs and you're working with a lab, it charges you extra to do validity testing on a specimen. You should switch labs because you should not be testing any urine that isn't tested for validity, and there should not be an extra charge for that. As I said early on, in forensic testing, you gotta have multiple tests. You can't just do one test and get a forensically defensible result. In drug testing, you have screening and confirming. In validity testing, kind of the same thing. You have creatinine and specific gravity. You test creatinine on everything. If it looks low, then you confirm it is actually low or not by testing specific gravity, okay? Also test acid base, pH, and do general screens for oxidants, which are the most common adulterants that are out there still today. The most important things that we see all the time are issues about creatinine. Creatinine, even though it is only one test, gives you a very good hint about the concentration of the specimen. That is important because the solution to pollution is dilution. The easiest way, remember we're using cutoffs here. We talked about cutoffs earlier. The easiest way to dilute out a drug is to dilute the urine, right? When the concentration of the urine goes down, concentration of the drug goes down. Concentration of the drug goes down, it gets below the cutoff, and what do you then get from the laboratory? Is a false negative. So just for information, the average creatinine in the country is around 130, somewhere between 100 and 150. We have a huge range of acceptability, all the way down to 20 milligrams per deciliter. That's a huge range, but understand that a creatinine level at 100 is different than a creatinine level of 70 or 80, even though 70 or 80 is within range. Remember, as the specimen gets less concentrated, the drug and the alcohol in it also gets less concentrated. Now, Dr. Price studied a whole bunch of workplace specimens, and this is what the guy found. When he took all those urine specimens and concentrated them up to a level of 100 milligrams per deciliter, he found that the positive opiate number percentages increased 18%, amphetamine positive increased 58%, and marijuana positives increased over 100%, simply by concentrating the specimens. All those specimens reported out as false negatives. So, solution to pollution is dilution, and here's how you do it. This was a study done a long time ago when I was just a kid. People started, look up here with a creatinine of 180, and they gave them some water. And look at the precipitous drop in creatinine in the first hour. See how fast you can dilute a urine specimen. When we have people giving us dilute urines, we refer to this kind of data and try to instruct them what not to do to get a urine dilution, assuming that they're not trying to do it on purpose. When I talk to people and try to give them a plan of how to avoid specimens that are too dilute, I refer to this kind of data, and I'm trying to make the assumption that that person I'm talking to is not doing it on purpose. You never know for sure. But you can see here, if somebody really wants to dilute their specimen, it's pretty easy to do just by starting to drink about an hour before you get to the collection site. Now, this study started with creatinines in the 180 to 190 range, as you can see. But remember from the previous slide, what I told you the average creatinine is. So if you get somebody around 130 that starts drinking water like that, and you know that the lowest acceptable creatinine is going to be 20, you can superimpose those lines there down a little bit, and you can see how quickly they can dilute out that specimen, almost beyond where we can accurately test it. It's not that hard to do. So we've mentioned false negatives more than we mentioned false positives, but we can't ignore the fact that there's going to be false positives. Poppy seeds, you know about. I hope when you have somebody that you're working with that is in a testing program, you tell them they can't eat poppy seeds, because if they do and they pop positive for morphine, you're not going to accept poppy seeds as an excuse. It happens every day. We see results in very low morphine and codeine concentrations, and people say they ate poppy seeds. Honestly, when I get that, there's no way. I cannot prove for sure the test results of poppy seed. There is no poppy seed biomarker, like an alcohol biomarker. It just doesn't exist. Thebaine was looked at in the 90s as a possible poppy seed biomarker, but it just didn't stand the test of time. And so today, if you get any morphine positive that's in a very low range, it becomes a benefit of the doubt issue. You want to believe that donor or not? So please tell your folks, stay away. Read the labels, make sure poppy seeds are not in what they eat. The biggest problem with false negatives, we just talked about, specimen concentration. The other question I get is, why didn't somebody test positive when they're taking a drug? You've got to look at the panel too. Remember, everything we're doing is a compromise, told you that. So we have lots of different test panels, and each panel doesn't necessarily include every single drug. Now, there's a whole lot of prescriptions that are not on every testing panel. So if somebody's not testing the way you think they should be testing, just first of all, make sure the specimen's not dilute. Second of all, make sure the drug you're looking for is actually included in the panel. A lot of times it's not. Drugs are also present in terms of isomers. You have to know a little bit about isomers. I'm not going to spend a lot of time today talking about it. But right-hand, left-hand issues with drugs could also be a big issue with that. And drug present below cutoff, again, specimen concentration issues. So best way to pass a drug test is not to take one. Urine has a short detection period. If you mess with the test, you get the urine collected, specimens dilute, goes to the lab, you get the lab report back. A week later, even 3 days later, the 3-day urine detection period has passed. You collect another specimen from that person, you're testing a different period of time. and that person has effectively passed the drug test by not taking one. So we do everything we can to try to save a drug test. Sometimes that takes longer in the lab to do that. But if you get a gray area test result back, maybe collecting another urine is not the best idea. You might want to test hair or PEF or something that has a longer detection period so you can cover that same period again. Best way to pass a drug test is not to take one. Any invalid test, any very, very dilute test can be looked at as a test that just was not taken. Okay, still, sensitivity is the most sensitive, urine's the most sensitive matrix. Remember what I said about alternative specimens, they're way less sensitive. But using them all puts everything in perspective. Bottom line, again, negative hair doesn't invalidate a positive urine. Okay, another case. 1.5 milligrams per deciliter specific gravity and creatinine and an acceptable specific gravity. So if you have a really, really, really low creatinine, I don't expect you to know these numbers, don't worry about it. Bottom line, really, really low creatinine and an acceptable specific gravity. How would you interpret that result? You're looking for a screening test and a confirmation test. You expect those measures to parallel each other, right? So if the creatinine gets way low, shouldn't the specific gravity get way low too? What happens if it doesn't? It makes no sense, right? Makes no sense. We can't prove that that person tampered with the specimen, although, you know, if you get creatinine down that low, the fact that that cup might have just gotten dipped into some water somewhere has certainly got to be in your mind, because that happens. But the answer to that is that it's an invalid specimen. An invalid specimen doesn't give you a result. Remember what I said, the best way to pass a drug test. This person has now not taken a drug test. Now, if this collection was supposed to have been observed, some of you have heard me talk before, know what I call observed collections mythical. It is not necessarily fun to be a collector doing observed specimens. You have to have the donor, same-sex donor, okay? I don't care if you're a health professional or not, same-sex donor, same-sex collector. Full exposure, turn and watch fluid from meatus to cup. So it ain't fun. It's not fun for the donor and it's not fun for the collector. So I have the myth of observed collections because nobody likes to do it and the collector kind of averts their eyes a little bit and they just don't really see what's going on. A lot of times from that kind of an observed collection, you get an invalid specimen. Remember back for the hair thing we talked about, talk to the collector. A lot of times we call collectors when we get invalid specimens with these kind of numbers on them. And we say to that collector, what did you do exactly? How did you observe this thing? And they're going to say, well, I did this. I say, you know, we got to pin them down sometimes. A little bit of third degree here because nobody likes to admit they kind of didn't do what they were supposed to do. But a whole lot of cases when you see a result that doesn't make sense, accept the fact that it is a nonsensical result and look for the reason for that, as opposed to some kind of bizarre medical diagnosis. So the specimen is inconsistent with normal urine. Notice that I said normal urine, I did not say human urine. Back when this was first starting in the 90s, SAMHSA said we had to report these out as inconsistent with human urine. So then, you know, what you spend the whole time talking to, what is it? Root beer? What is it? Dog urine? What do you mean human urine? So we stopped doing that just because it's not a discussion we want to have. And it's not consistent with normal urine, so we can't test it. Now, absent a very unusual medical condition, there was a collection issue. I will say that in the 30 years I've been doing this, we found some people in kidney failure. We have found that. So again, I know we're in a kind of profession where we get lied to a lot, but you know, they're out there. You kind of have to look, you kind of have to ask the questions, and you kind of have to pursue leads if there are leads that you get at least up to a reasonable point. Yes, and we have diagnosed some people in kidney failure. Bottom line, absent that, the donor probably tampered with the specimen and got out of taking a drug test. So Okay, now we're switching to metabolites, and this is what I'm going to kind of whiz over because I want to touch on biomarkers, and I don't even have time to do that. So, Suzanne, do we have any questions before we change topics again?
Yes, you do. Ginny Matthews has a question. If you wanted to mention,
hi, Jenny.
If you wanted to mention the creatinine levels they had last summer between 1.8 and 5 with specific gravity of 1.006 and up.
I'm sorry, Suzanne, say that again.
Yeah.
You're giving me numbers here.
Yeah.
No, you're talking about the case. I see you talking about it, but some of those actually would have come in as valid because, well, they did come in as valid because they were over 2 and the specific gravity was elevated. Similar to the case you were just talking about, but they might have been missed because they weren't dilute and they weren't invalid. That's all. I was building on the case you're right.
And remember when I was talking about the creatinine levels, okay, the average creatinine in the country is 130. But SAMHSA, in their wisdom or not, has ordained that we're going to accept creatinine levels down to 20. Okay, these are huge ranges. There is no such thing as a gold standard test. There are going to be examples where, and that's the whole point of some of the things that I'm saying, is to give you an idea about average creatinine versus the numbers that you're seeing here. If you have average specific or acceptable specific gravity and creatinine's in 19, that still doesn't mean you have a very good, accurate drug test, simply because of the dilution of the specimen. And yet we are going to report it as valid. You're right, because this is a forensic program and we cannot deviate too much from what SAMHSA tells us we have to do. So as intelligent, knowledgeable end users, you all can look at these numbers and raise questions. And there is always subsequent follow-up testing that can be done. One of the ways around dealing with these long, bizarre ranges is what I said earlier, is mixing up your specimens just routinely, even if you don't have any obvious reason, like an invalid report, any obvious reason to do it. Routinely mix up your specimens. You're going to be surprised what you get. You can't imagine how many PEth positives I get in people that have interlock devices. Okay, I can give you lectures on how you beat SoberLink. I'm sorry to my friends at SoberLink, but I can give you lectures on how to beat them and how to beat an interlock device. Okay, that just because you have that type of device doesn't mean you shouldn't be doing PEth or urine. So the way you're going to get around all these things that Jenny is properly talking about is by mixing up specimens, mixing up your random testing program. Okay. Anything else?
Nope, that was it.
Okay. With all the issues that we talked about so far, one of the ways that we have to try to cover ourselves is by looking for both parent drugs and metabolites. Especially in hair testing and in nail testing, we have serious issues, as I've said earlier, about contamination. We need to see metabolites in this testing, much more than in workplace testing, much more than in SAMHSA testing. We look at metabolites as our main analytes. That really tells us the story. Much more important in hair than it is in urine, and much more important in oral fluid than it is in urine. But even in urine, for some drugs, the diagnosis is not made by the drug itself positive. It's made by whether the metabolite is present and how much metabolite is present. Specifically opioids, benzos, and meth. Now this is a complicated slide about opiates. And I hate to tell you this, y'all, but it's not nearly as complicated as opiate review actually is. Okay, there are many more metabolites than we could find little box rooms on this slide. But this is just a sense of how many different things that we need to look for in some of the testing that we're doing to talk about ingestion versus exposure. Okay, the parent compound in the vast majority of cases, opiates especially, the parent compound is eliminated much more quickly than the metabolite. That's why we look for metabolites. The more metabolites we have on the testing panel, the more likely we are to find out whether or not there was ingestion, because hydrocodone, codeine, all of those things are eliminated much more quickly than norhydrocodone, hydromorphone, oxymorphone. Those are the things that hang around, and those are the things that we look for. It's very common that we see positives only for metabolites. No parent is there. And you have to know, especially in the amounts that some of the folks are taking them, where you see huge doses that are being tested for, we may see some really surprising metabolites in very, very tiny concentrations. That's why we have those kind of graph slides like I just showed you. Given that, we still don't rely on ratios or anything else that we used to teach 30 years ago. Over time, we just have to accept the result as ingestion in the detection period and not try to nail down exactly when the drug was taken or how much of the drug was taken. So codeine and morphine produce minor metabolites. Hydrocodone produces a whole lot of very tricky metabolites. Codeine and morphine are the worst. So you can see when a lot of codeine is present, you can even see a little bit of hydrocodone. When a lot of morphine is present, you can see a small amount of hydromorphone. So you just have to keep in mind that when we see large quantitative numbers, you have to look beyond the numbers. Okay, I think we are about at the end of the time, Suzanne. Do you want me to keep going, or what would you like me to do?
We have 3 minutes. I don't know if anyone has any questions for you.
Well, if you all invite me back, we can talk about biomarkers next time in a greater detail.
Does anyone have any questions? You can unmute yourself and ask if you'd like. These slides will be available on ASAN's website, so you can review them. And if you have any questions, you can contact me and I will give them to Dr. Ferguson to answer. True, you will. Okay, well, I guess that's it for tonight. I want to thank everyone for attending. I would encourage you to become a member of ASAN, go to our website, join ASAN, and come back and look at our website, because we're going to be having monthly webinars once a month, September, October, November, and December. That should be posted probably within a week or two. And we invite you to come back and join another webinar. Thank you very much, Dr. Ferguson. Please invite him back. That's a comment I received. And everyone have a good night. Thank you.
Bye-bye.